we saw an increased use of any tool that we had available to us that would not cause this person to have increased exposure. But with all medications and with all treatments, you add additional risk, even as you are increasing the benefit, and you're continually weighing those two things. The pandemic on nursing homes in particular, very challenging both for our patients who were likely highly distressed. And when someone is increasing in their distress or neuropsych symptoms, we then respond in the most helpful way we have possible. I will add, it was also extraordinarily distressing to our workforce. Of the nursing workforce, we didn't lose anyone more than we lost in the long-term care nursing world, which is exactly where we need people the most. So it was distressing, related to high levels of burnout. Remember, those nurses didn't leave the nursing home world, they left the profession. This is something they may have committed their entire education and career toward. Maybe felt very passionate toward taking care of older individuals, especially those who need a lot of hands-on direct care, and were so burnt out they could not continue in that role. It is hard to overstate, I think, how challenging it has been for us and how much we hopefully have learned about both weighing non-pharmacologic interventions and how very important those were right alongside the pharmacologic interventions. I think in so many areas we're trying to leverage our lessons learned from the pandemic, including how we manage neuropsychiatric symptoms and how we best provide care in residential care settings. For a long time, we felt as though we should improve the quality of care in nursing homes, and there's a strong momentum toward doing that. There are a number of recommendations that hopefully will be enacted. The challenge is widespread enactment through policy. That's a pretty tough thing to do. We make policies that are very well intended. They make perfect sense when you really back up to what is it we're trying to achieve. Implementing those broadly through things that are more objective in scenarios like neuropsychiatric symptom management, which is nuanced and individualized. Really challenging to do something like that at a population level. Sometimes we try to get at it by better diagnosis, so we have new diagnostic codes. Sometimes we look at quality measures, and I am passionate about improving quality. Measurement is tough. Measurement is its own science, developing measures that matter, not just measuring what you have available. But in reality, what we most often do is we measure what's available. It may or may not be the thing that really matters to patients. So that's a challenge in the case of the neuropsychiatric symptom management, particularly with the use of certain types of medications like antipsychotics. We want to measure it because we are hoping for good quality. Who would argue against better quality care? But in reality, what we want to know is the nuance of how are this person's symptoms managed, what benefits are they realizing from this treatment, and have we considered the risk and then minimized the risk to the best degree? And what level of risk is this patient and or their family willing to take in order to reach those benefits?